Hello, my name is Jasmine Charles. I'm a PA. I work with the University of Utah Maternal Fetal Medicine Department, and I am the clinical director of SuperRad, the Substance Use and Pregnancy Recovery Addiction Dependence Clinic. Today, we're going to talk a little bit about sex, drugs, and how to let you rock it, not let it roll right over you. Couple things about me, housekeeping-wise. I am, like I said, a PA, a physician assistant. I'm the clinical director for SuperRad. I'm also an associate professor and clinical associate for the University of Utah Physician Assistance Program, and I am the clinical rotation coordinator for the University of Utah PA program within the OBGYN department. Pictured here is part of the core team of my clinical team. There are 25 of us in all that work together. Disclosures, I don't have a whole lot of them, but I am a part of the medical advisory committee for the Gilead Science team, looking at hepatitis C treatment for pregnant and postpartum women. I'm also on the MOMS CTN trial. I'm a medical clinician for that team. I am a contracted clinician for the Salt Lake County Jail and take care of all women who are pregnant and incarcerated there. I'm part of advisory committee for House Bill 318 and 418, and I'm on the advisory committee for the opioid safety bundle. Objectives for today's talk, we're going to really focus in on universal screening for substance use disorders, particularly opioid use disorder. We're going to talk about clinical time being valuable time because all of us are running on borrowed time, as in you can bill for this, and let me help you know how. We're going to talk a little bit about urine drug screens, and then we're going to talk about when you should refer out versus when you, as a clinician, no matter where you work, could possibly provide the care for these individuals. And then we're going to talk a little bit about child welfare to report or not report here in the state of Utah. 3 things to remember throughout our time together today is that death is a really important factor here. Addiction is like diabetes, high blood pressure, bleeding disorders. It is a chronic illness. And the words you use are important. So say a person with addiction, not an addict. We will start with universal screening. We're going to talk about how it's in the words you use and how you say it. Patient-centered language is actually what's going to bring it home here. Motivational interviewing and working with each individual as a human, which is what we are all trained and what we come here to do. We're also going to look at using validated screening tools, which the important thing to remember is that no tool is better than another, and we'll talk a little bit about the studies that looked at that. And then, again, like I said, we'll round back around to some billing. Whenever I talk to people about what I do for a living, and as soon as substance use disorders come up, and particularly when I put it together with women who are pregnant, it's like I've opened the can of worms and the elephant in the room is set free. This is one of my all-time favorite images because this is how every one of us feels with the elephant in the room. That could be anything from having to give a diagnosis to an individual that we don't want to give, having to talk about a conflict at home when we face difficulties with our spouses, our children, our parents. It's like when religion or politics comes up around the Thanksgiving table and we're all looking at each other and really uncomfortable. So this elephant here talks about all the factors of what we are going to have to work towards in order to bring up the elephant in the room. Asking people about substance use history, current substance use, tobacco use, alcohol use is like that elephant in the room. It's 2 factors. 1, for a lot of us, it's a really uncomfortable topic, and that may be because we don't know what to do once we've opened the can of worms. But 2, it's also a time sucker. We're afraid to ask because then in turn it means I need to take a few more minutes to figure out how to help. 3, it's one of those conditions that you cannot solve in a single visit. Somebody comes in and they've got a sore throat, you swab them for strep throat, they're positive, you treat them with amoxicillin, done. You can say, I took care of that problem today. A kiddo comes in with an ear infection, same concept and same pathway. Substance use disorder is a lifelong chronic illness, and once you open the can, you've got to be ready to help people on their journey. But that does not mean you have to follow that journey on your own. And most importantly, you first have to figure out if it's even a journey they should be on. So, like I said, we're going to talk about the words you use. If we all sat down every day and thought about everything that we said, there's probably daily something that we can think of that we thought, that one I shouldn't have said, or in that setting, I shouldn't have used that word. I spend a lot of time in clinic utilizing non-clinical terms once I get to know my patients because I try to help my patients feel like we're on the same conversation level. But the one thing I do regularly work to correct and educate on is the appropriate use of language when it comes to substance use disorders. It is not just important for you so that the individual feels like you are a safe and welcome place for someone, but it is important in the individual's recovery journey. If you spent every day saying that you were dirty, you too would start to feel like you really couldn't overcome the challenge you're faced with. So this slide just shows you a few of the things, the take-home pieces and words that a lot of us use that we can try and adapt. Clean and dirty is the one I'm going to focus on because we talk a lot about urine toxicologies. And I don't know about y'all, but in my mind, anybody's urine, including my own, is always dirty. It doesn't matter what substance might be in it. If in a clinical medical setting, I have to put on gloves and eye protection in order to handle it, it's dirty no matter whose it is. We like to say expected or unexpected or as expected, because even if the individual has admitted that today they will likely have urine that shows us remnants of heroin, of methamphetamines, of alcohol, that's an expected urine. Negative and positive, which are medical terms, also okay to use, but the clean and dirty factor are ones we've got to try and put away and also help our patients do the same. A lot of you have probably seen this specific slide in other talks, talking about saying this and not that. This is a poster that you're able to get a hold of and actually hang up in your offices. It's one of those unspoken words that you can put up that kind of shows that you are a welcoming and safe place for someone to start to embark on talking to you about this chronic illness that maybe they haven't been ready to talk about. And strength-based language is actually what we can give back to clients and their families. When we're working with an individual, we've got to remember that oftentimes there are a bunch of other people surrounding them, whether they be their support or their negative outcomes from the situation. So working with an individual or with their families to understand the chronic illness process is very important with substance use disorders, but particularly, again, back to those things like saying addict, instead using person with a substance use disorder. Another big one that we often use in clinics is that you are resistant to care or you're manipulative about your care, that you're lazy about your care, and instead talking a lot about being ambivalent or not ready to come to care. And then to remember with resistance that choosing not to is not resistance. That's a choice they've made. When we talk about the words we use, we also, because we're talking about women with substance use disorders who are pregnant, need to look at the children who, if they choose to continue their pregnancy, will be born. Really important take home is that infants cannot be born addicted. Addiction is a chronic illness that is a change within the brain pathways, and therefore, at birth, you cannot come out with an addiction. Infants and newborns can be exposed. They can have some withdrawal process, which is that neonatal opioid withdrawal syndrome or neonatal abstinence syndrome, but they are not born addicted. Media and society loves to parade around, which you see here, a couple of different situations of which have been advertised for addicted babies at birth. It is not a correct term. Please, if you do anything today, if that's one that you've often used or ever used, to try and remove it from your vocabulary. So back to that screening world. The first question I'm going to go ahead and ask is I'm going to have you take a moment to look at yourself and think, what do I screen for in my clinical world? As obstetricians or family practitioners that take care of pregnant or potentially pregnant women, I'm sure the majority of us, no matter where trained, how trained, or what license you're trained under, are very adamant about screening for mental health, whether that be depression, anxiety. We screen for high blood pressure anytime somebody walks through our doors. We put on that blood pressure cuff, we look at the number. We all know that there's an algorithm that gives us an outcome of, is that hypertension? Is it not hypertension? Particularly in women's health, we're looking at STIs, chlamydia, gonorrhea. And then if we're back to specifically pregnancy, we're looking for things like anemia, cystic fibrosis. If you look at this slide, this is a poll taken, and this is a slide from ASAM, the American Society of Addiction Medicine, asking providers in 2016, what percentage, who screens for the following things? When asked if they screen for substance use disorder, 15% of providers said yes, which is the same number of providers who said yes to screening for anemia. So the important thing to remember in this case is that of those 15%, when they are saying that they are screening, the other question would be, are you screening everyone? Or are you using your implicit bias to decide who and when you're going to provide the screening tool? Because if you are not screening everyone, it is not screening. Why screen for substance use disorders, and particularly opioid use disorders in women of fertility age? Well, because 15 to 20% of our population has chronic pain at some point in their life. That is the baseline number, okay? And 15 to 20% of those people with chronic pain have an underlying addictive process. But the big take home is up to 40% of patients who are given opioids for chronic pain will develop a use disorder. So 40% of individuals who over time are given prescription for opiates will develop a use disorder. I would say for those of us who have been through some medical training, if we think of statistics, we spend a lot of time looking at 1%, 2%, 5%, 7% of the population. This is 40% of individuals who, if we don't ask, we may never know that they have a chronic illness that needs some help, that potentially initiated from trying to take care of a chronic pain disorder. The other reasoning is because of the demographics of chronic pain, okay? So most predictive risk is that if we have a personal or a family history of alcoholism or other addictive disorders, more likely to be in that 40%. Women more likely to report any use of prescription opioids. And in all honesty, women are more likely to be given opioids for pain and in higher doses. Women were also more likely to report the use of any prescription opioid, and women are given these medications in higher volumes, higher numbers, and more frequently in their childbearing ages. And these are the women that we are caring for right now. So we go back to the screening tool itself, because now hopefully we all know that it is a prevalent problem and something that if we screen for it, we will find it. If we find it, what do we do with it? But how do we screen for it? Okay. So a lot of us in our daily care walk into a room, talk to a patient, ask a series of questions. We were trained, they're like ingrained in our brain for our whole life. You know, how do you feel today? What brings you in today? What medications are you taking today? Sexual partner, male, female, both. Talk about medications, talk about smoking, alcohol use. It should also be a routine to talk about other substances. But we also know that when asking directly, we are less likely to receive an honest answer and a straightforward answer because the patient is more uncomfortable to give us the information. So we look at this SBIRT theory, which is screening, so that we first have the information to then be able to give a referral and also be able to provide a brief intervention. In the screening world, that means that we can provide a pre-visit screening, whether that be that our patients have access to electronic questionnaires pre-visit, or even when they arrive in clinic. Once we check them in and put them in their room, we can hand them a clipboard, they can check them off, hand them an iPad, they can check them off. And that's what we're going to talk about, is what screening tool am I supposed to use? What do? I want to screen my women who are pregnant at their first obstetric visit for substance use disorders. Where do I go from there? So again, screening is not based on risk factors. It's not that you look down who this patient is. Oh, it says on here one time that they came in and said that they're smoking tobacco, therefore I should give them a substance use disorder screen. This is that paperwork you hand to them, just like the HIPAA paperwork, just like the tell me who you are and what insurance you have paperwork. Everyone answers these questions. That is what screening is, universal screening for all. There are 3 primarily used screening tools. There's the 4 Ps, which just stems from 4 questions. Have you ever used drugs or alcohol during pregnancy? Have you had a problem with drugs or alcohol in the past? Does your partner have a problem with drugs or alcohol? And do you consider one of your parents to have an addiction or be an alcoholic? The second option is the NIDA Quick Screen, which this is the tool we will talk more in depth about. But the thing with the NIDA Quick Screen is it's ideally done online, because if they answer yes to any of the initial quick screen questions, it will then prompt a more in-depth questionnaire so you get some more answers. Third option is the CRAFT, which is actually designed for those under the age of 26. So we're looking at our adolescents and then our younger adults. All 3 are tested, all 3 are validated, and none of the 3 are seen to be superior to the other. This was found by these couple of research studies, the accuracy of 5 self-reported screening instruments for substance use and pregnancy in the Journal of Midwifery and Women's Health, Screening for Substance Abuse in Women's Health. So a public health imperative. They looked at and compared 5 screening tools, and none was found to be superior from the other. So back to that NIDA 4. So these are those big questions, okay? And there's technically 5 questions, but they call it the NIDA 4 because if you are in a state of which marijuana is legalized, then the 5th question becomes a little bit different. So in the last year, so it's in the year, have you smoked tobacco or vaped? Had more than 4 drinks of alcohol in one day or more than 10 in 1 week? Used a prescription for something other than prescribed? Used an illegal or illicit drug? And the 5th question is used marijuana. So the Trick here is, again, like I said, if you say yes to any of these, it will prompt an additional screen. I'm going to empower each one of you to Google NIDA Quick Screen. It will pull up the NIDA and go ahead and you can play with it, you can look through it, you can take your own. I will sometimes even do this with patients who are trying to ask more questions about their partner or what kind of help their partner might need. I'll say, take a NIDA Quick Screen home. If you have access to the internet, here's how you can get there. If you don't, here's a paper version. I will forewarn that if you plan to use paper for the NIDA screen, the entire screen is 7 pages long. So for most patients, that is just too daunting. I don't know about you, but once I get like halfway through the page of a questionnaire, I'm kind of done. But on an electronic form, it just pops one question at a time, and it can be done in under 10 minutes. So this is what it looks like if you're looking at it online. Again, asking about an alcohol asks for men versus women, that tobacco question, that prescription drugs for non-medical reasons, and then that last question, illegal drugs. And they're going to say never, once or twice, monthly, weekly, or daily or almost daily in the last year. And then, like I said, you say yes to any of those, and we move on to the NIDA Modified Assist. So this is questions 1 through 8. And it's specifically looking at if you have said yes to illicit drug use. This is the one that we kind of helped you to carry on through. Looking at, in your lifetime, which of the following substances have you used? Hallucinogenics, street opiates, prescription opiates, other. Again, they say yes or no. If the patient says yes to any one of them, they're going to go to the next question. And in the electronic version, it just clicks you to that question. In the paper form, it asks you to move to question 2. So you also have to be able to navigate on the paper form. So again, if you are unable to provide a electronic screening for the full screening to your clientele, ideally for you will likely be the 4 Ps or that craft if your patient population is under 26. Just a few more ways of looking at and seeing a little more of the NIDA. So in the past 3 months, how often have you used the substances you mentioned? In the past 3 months, how often have you had a strong desire or urge to use those substances? And continuing on from there. Also asks specifically about the control you've had over your life, what you may have done to obtain substances, and then if you have friends or relatives who expressed concern. So a very thorough screening of which is not taking up your time as a provider, your team's time, whether that be your MA, your RN, your social worker. This is a patient one-on-one with their questions, answering those questions. This here is the link to the actual online NIDA screen. It is free for use. You do not have to purchase it. You are able to go ahead and have it uploaded onto a system and utilize it within your clinical setting. This is probably the important part for you and I. So again, time is of the essence. When you're a provider, you have 10, 12, 15, if you're really lucky, 30 minutes with a patient. They've got to do this paperwork, they've got to answer these questions, and then you have to do something with the answers. You do not have to go through every one of these NIDA questions. If this is done electronically, you will receive this beautiful stoplight diagram in the end that tells you red, yellow, or green, meaning high risk, which means your score was higher than 27, moderate risk, your score was 4 to 26, or lower risk, your score was 0 to 3. So the other important thing here is, but what do I do with that? And you as a provider and as a team have to have a plan of what you're going to do with that. Because this screening tool is not useful if you end up with an answer, but you never have a conversation with the patient. Now, most of us kind of hope for that green light, right? And we think with the green light, we can just like slide the paperwork aside, check off that we did it, bill for the expert, and go move on. But in order to bill for the expert, remember that we had a potential referral and that we had a brief intervention. So those green light patients, the ones that have a lower risk, which means they probably on those first questions said nothing, they're the individuals that we then sit down and say, thank you so much for answering those questions. Greatly appreciate it. I noticed you had a really low risk. I just want you to know that if it ever becomes an issue or a situation or you have a concern or you have someone else that has a concern, this is a safe place to come. Happy to answer questions. Congratulations on healthy lifestyle choices. That moderate risk, that 4 to 26, which is a really big gap, this is again that feedback. So no matter what the score, you thank them for taking the time and for giving you the information, okay? But then you're gonna need to advise, assess, and assist. So you need to talk with them and ask a little more. The questions will help you know which questions they said yes to. So is it about tobacco? Is that something that you can easily and comfortably talk about in your office? Can you provide them with the quit line information? Can you ask if they're ready to quit? Patches, gum, Wellbutrin, Chantix. If it's opiates, are you an office that is able and to have a little conversation about buprenorphine, or about even ultimately asking the patient if they're ready to have a conversation and if it's okay to have a conversation. And then we all get real sweaty about those high riskers. This is where you would likely provide a referral unless you are somewhere that this is your bread and butter and you are very comfortable with working with substance use disorders. And based on, today we're talking about opioids, so if you're looking at opioids in a pregnant woman who's got opioid use disorder, who can help you? And we're going to talk about that. We're going to talk about where you could refer to versus who could possibly stay in your office. In summary, so asking about substance use is the important piece. And in all honesty, asking permission, maybe even more important. So asking permission to have a conversation about substance use, asking permission to have a conversation about the results that came out of their NIDA screen, because you want to invite and welcome that individual to be in charge of their own care. It's their chronic illness and it's their journey. You may be the one with some knowledge or some resources, but you are not the individual living it, and you don't have all the answers. Secondly, motivational interviewing is very beneficial in a lot of contexts, and that even goes all the way back to filling out the screening tool, because you may have people who are like, I don't need this. That is great to hear. We screen everyone just so that people are aware of what we may be able to provide people with, and you may not need help from your screening answers, but maybe you know somebody that does, and that maybe in answering the screening questions you realize that you've got somebody that might be able to come in and get some help. And then another big take home is we're talking about women who are pregnant with substance use disorders and screening them. Pregnancy is really powerful. 80% of pregnant women who have a substance use disorder will go into remission and stop use of whatever substance it is without any intervention from any of us. And so the ability to be able to provide the extra hand up to help them through that process and then postpartum help them remain in control of their chronic illness is a pretty powerful thing to do. But if we don't ask, there are for sure thousands of women going without any access to help. Again, screening should be universal, because if we are not screening everyone, we are putting in our screening bias and we're not screening. And it's just like screening for anything else: depression, preeclampsia, hypertension. The other important thing is the screening tool may give you a high risk result. That does not mean you have a diagnosis. So you cannot then turn around and mark on the chart they have opioid use disorder, methamphetamine use disorder, stimulant use disorder, alcohol use disorder. That is that separate DSM-5 criteria, which we are not talking about today. This is screening. This is screening for who needs more information, who needs more help, and who needs some help so that we can help them figure out what the diagnosis is. This is the take home that you all want. This is provided to you as a handout, separate from this talk. These are the billing codes. So for any one of you who hands somebody a NIDA screen, or a craft, or the 4 Ps, you can bill for this. This talks a little bit about Medicaid, Medicare, commercial insurance. Somewhere between $24 and $57 can be recouped from insurance if you bill for it, which is just a matter of dropping in that code. Please remember that you have to actually do it in order to bill for it. But if you're doing it routinely, then it's a billing code you can drop in for every single patient. So we've closed our section on talking about screening, and we're going to move on to talking about urine toxicologies. Because urine toxicologies are often considered screening, but they are not a screening tool. So why do we use a urine toxicology? Because it can be a part of our screening tool. It can be a follow-up to our screening tool. Some places it is utilized in order to be allowed to be seen within the clinic. But we're going to talk just a little bit about what does urine toxicology mean, why might you use a urine toxicology, and the biggest thing is that urine is not a punitive finding. The other important take home here is that you cannot screen a woman without their knowledge. So you must have permission to obtain a urine toxicology. Part of the reason you must obtain permission is because there are false positives and there are false negatives. And these false positives and false negatives can have very big outcomes for a family. This slide here is one of several lawsuits that have come across medical facilities because of a false drug test that almost cost a mom her children. And so then she sued the hospital. But the other thing to remember is they're not punitive findings unless you're in the court of law, they're supervised, they have a chain of command. What you are doing in your clinic cannot be upheld in a court of law because this is that individual's HIPAA and their right to privacy. And just because you are having a conversation with them about their urine toxicology does not mean that everybody else is going to have to know what's in that urine. This slide here is just to kind of point out and bring home the rate of false positives and false negatives within a point of care urine toxicology. So point of care is the one where you like pee in the cup, put the little dipstick in there. Some of them have cups that have that colored line on the side that tell you what substances may be in there. It's giving you an immediate result. It's the same as your 10 dip when you're looking for an infection, or even your 2 dip where you're looking for protein and glucose. It's a instant, if not within 10-minute result. They have a higher rate of false positives and false negatives, which makes sense because it is an immediate result. So 99% of methamphetamine results that are positive within a urine point of care drug screen can be a false positive, okay? So it's a big deal to then go ahead and have a conversation or to look at the next step. In our clinic, what we do is for every point of care urine toxicology that is run, if there is an unexpected false positive, we run it for mass spectrometry because that is confirmatory testing. So individual turns around and says, I've never used meth. Why is there meth in my urine today? That's not real. I hear you. I respect you. I also believe you. I have sent it off to confirm so that we can confirm that it is a false positive. Now, a lot of people ask what happens when it comes back and it's not a false positive and you have positive amphetamine and a positive methamphetamine level in that mass spectrometry. Well, that's where you have the next step of a conversation. I am here for you, and this is your journey. Talk to me. Your results are showing me that the methamphetamine is a positive, and this is the confirmatory testing. It does not mean you are removed from the clinic. It does not mean that there's any punitive negative things that happen for you. My concern is that we have a finding, and I just want to know how I can help you on your journey. But you've got to always be fully aware of those false positives and false negatives. We're going to talk through a few specifics because there are some very specific things that cause high rates of false positives. This is a lot of us are like, well, how long can we find things in urine? How long are we looking for these? Methamphetamines, anywhere from 1 to 4 days, usually are going to come out positive. Benzos can remain within the system for 1 to 30 days. Opiates from 1 to 4, most primarily, but some of them can lag for 7. Metabolism is an important player here, and you will have people who say, I'm a slow metabolizer. My urine toxicologies show you a positive finding for twice as long as anyone else. Okay, great. That's where you've got that mass spectrometry. And what you should see is that number decreasing over time, even though your point of care continues to show you a positive. This is a nice, and again, this is one that you have access to in handouts, 1-page summary of your most common false positive causers. It also shows you a few false negatives. So in the world of benzodiazepines, which is one of those scary, dangerous worlds, your lorazepams, your alprazolams, and your clonazepams can be falsely negative in that urine toxicology. In the opiate world, which is the kind of the big take-home one for us today, all of your H1 blockers, your Sudafeds and your verapamil, all risk for false positives. So in the world of pregnancy, we use a lot of H1 blockers, right? Women have GERD, they have reflux. And we use a lot of Benadryl. Women have nausea and women can't sleep. Those can both provide you a false positive in that opiate, which is where it is important to then quantify that. And then amphetamines is the other one we kind of look at, your pseudoephedrins. So if they're taking Sudafed, that can give you a false positive. And Wellbutrin is a big one, bupropion. So looking at what is the individual taking, looking at their med list. It is also helpful ahead of time to look at the med list and think there's a high risk that we have a false positive and just be prepared for that and also be able to prepare your patient for that. If they are receiving urine toxicologies within a legal system, probation, child welfare services, even at work, it is also really nice to be able to provide them with this information. We are starting you on bupropion. I know that you are somewhere that is regularly doing urine toxicologies. I want to let you know that this can be a cause of a false positive for methamphetamines. Are you interested in me providing you a letter or the education that you could give to those individuals in order for them to know that you are on this medication? This specifically talks about cocaine and cannabis and things that make a higher risk for false positives. Protonics is the big one with our cannabis friends, and the topical anesthetics containing cocaine, which are actually pretty rare, but can cause a false positive for cocaine, as can fluconazole. As can matcha tea, the one specifically that individuals like to put in a little gourd and you drink it through a straw. It is a downer and a sedative, and it can cause false positives. It also can have traces of cocaine in it, so that's why you also may have a positive from it. specifically opiates, poppy seeds, it is true. You can eat enough poppy seeds that it can give you a false positive on a urine toxicology screen. You would be able to quant that out, and in the breakdown of the quants, you'd be able to see that it's actually following a different pathway than your average opiates. Benadryl, again, verapamil, Robitussin, amitriptyline, all can give false positives. One of the important things to remember on amphetamines is that if a patient is on a prescribed amphetamine, they're going to be positive for amphetamine. They will not be positive for methamphetamine. So if a patient is taking a stimulant for ADHD or narcolepsy, then you need to be prepared for a positive amphetamine result. But if it comes up positive for methamphetamine, you're going to quantify that to see if it's a false positive or if there is alternative substances in the system. In talking about babies specifically, because a lot of mamas ask, well, how long can you see it in my system? What's going to happen to me? What are you going to be able to see with my baby? We look at two different things. We can look at meconium and we can look at a cord tox from the umbilical cord. Meconium forms at 2 months of age, and it looks at exposure in the past month or longer prior to delivery. So if there is recent use or ongoing use in the last month of pregnancy, that will not necessarily show up in meconium. So the other important thing to remember is that if you run meconium for a toxicology screen, this is potentially history and not necessarily exposure, because these individuals could show a positive result all the way back from week 12, week 10, week 20. And this mama could have gone into 100% recovery and be stable and in treatment and on the right track, but we still have a history of a positive result. It is more accurate than urine. And then if there's immediate use right before delivery, then we can have a false negative in the meconium result. For about 30% of our kiddos, they're actually going to pass meconium in utero, and we're going to really struggle to be able to get that sample. So it is a screening tool that is not usable in about 30% of our population. Cord collection is the other thing we talked about. We recently completed CPAST, a study here at the University of Utah and in the state of Utah, looking at universal cord collection for the rate of variety of substances found within the cord. The nice thing about universal cord collection and about this study was that there was no stigma and there was no identification. So we were able just to look across the board at numbers and not specifically at individuals who are willing to sign on to a study or provide their cord. Cords are detecting about 4.5 months prior to delivery. We here at the university use the ARUP lab because people are often wondering, well, what substances are we looking at? Opioids, cocaine, amphetamines, benzodiazepines, marijuana, so specifically THC, alcohol, and mitrogen, which is the metabolite of kratom. For those of you not familiar with kratom, it is a substance that can be bought at the smoke shops. It can be smoked, taken in a capsule form, taken in a liquid form, and it reacts similarly to an opiate. This concludes our look at urine toxicologies and then screening in our newborns. And we're going to move specifically to going back to that world of ESPERT and that screening tool of, okay, I have an answer, so when do I refer out versus when can I manage from within? We're going to talk a little bit about, again, what do you do with that NIDA screening tool, but also what resources are available. Because a lot of times, in all honesty, it's not what you know, it's who you know. What friend can you phone to give you an answer? Educate your patients and their family. That's really the biggest thing you need to do. Educate them that you are supportive of them. Educate them that you may not have the answer, but that you're going to help them find someone that does. And engage them in the decision making. If you provide a prescription of go talk to this person, go do this, and we're going to put you on some medicine, it is unlikely to be successful. If you lay out on the table all of the options, as well as the dangers of their condition or the status of their condition, you have given them all of the information, and then you can help them make a choice as to which way they want to go. Of course, if there is imminent danger, so whether that be that this individual has spoken of concerns for self-harm or harm of others, or if in some case you are someone who is encountering someone who has had an opioid overdose and you had to give Narcan, those are all emergency situations of which you are required to report and to give the next step of help. We are going to come back to this stoplight and remember that our lower risk 0 to 3 score people just need a reminder and a thank you for filling out their screening tool, and then also that you're always available for questions, concerns, or if anything is needed. That moderate risk score, that middle score, is where you as a team and a clinician have to decide, are we someone who can care for this pregnant woman? Are we somewhere that is safe and we have enough information and we can phone some friends and put some things together? Or are they a high risk and we should be referring them out? If you are not somewhere who on basically a daily basis cares for women with substance use disorders, pregnant or not, you are probably not equipped to care for those higher risk individuals. This is where what I do comes into play. So for those of you who live in the state of Utah, or a surrounding state, to be honest, Colorado, Idaho, Nevada, we're kind of your only shop in town right now. So this is Dr. Marcella Smid and myself. We started Super Rad 4 years ago now, and we are happy to help you navigate the world. We are happy to take your patient and embrace them with open arms and take care of them within our clinic. We are happy to consult with your patient and then talk to you about what we think you could do if you have a patient who either can't get here or you feel like you are really comfortable caring for that individual, you just need some information. We're also happy to just curbside consult and chat with you about it if you have some questions. We take care of women with all substance use disorders. The majority of our women have opioid use disorder or usually methamphetamine use disorder, but we do have women cocaine use disorder, alcohol use disorder, benzodiazepine use disorder. It just so happens that right now what's hot on the street are the opiates and the stimulants. So we are located in Salt Lake City, which is part of a challenge for everybody, but we do provide virtual care. So if you have a patient who you feel like you can co-care with us, we are happy to help see them on a virtual basis, walk through their specifically substance use disorder piece of things, and then have you continue on with their obstetric care. Alternatively, if you feel like it's just that one-time conversation, so they've been given all the information, we can do that as well. We can do a single consult. We take care of individuals and have collaborations within the treatment centers in town, methadone clinics, incarceration units, and we work pretty closely with Child Protective Services to be able to help and support mamas who are wanting to navigate the system and parent their children. SAMHSA provides us with a wealth of information and a wealth of access to information. The link is provided here and in a handout for you. Please feel free to navigate SAMHSA or have a patient navigate. There's a provider piece of SAMHSA information and there's family and patient side to the SAMHSA. Alternatively, if you're looking for resources specifically close to home here in Utah, the Department of Health has in the last year created a list of, I like to call it the yellow pages, of pregnant women with substance use disorder services. So there's services that are located in each county. You can have access to those who have buprenorphine waivers and are able to prescribe Suboxone. All those things are available to you at the provided link here. I will honestly tell you that to just Google Utah Department of Health and pregnant moms with substance use disorder, it's very difficult to kind of navigate through, which is why I have this link and we provide patients the link, because it does get a little frustrating to actually find the page. SAMHSA specifically offers this selection of handouts, of which we have available in paper form for patients, but we also help them to access the information online. It's specifically looking at opioid use disorder and pregnancy. All of them look very similar, but have different topic sections. The front side gives you an introduction, what you should know, something about specifically what the topic is, and then the back side shows us the do's and the don'ts, but also gives you a section where you can actually talk with your patient and have them write down some goals or what they would like to do and when their next appointment is. There's one about treating opioid use disorder during pregnancy, so it does talk about methadone, buprenorphine, and some options. It also talks about withdrawal and the risks of withdrawal in pregnancy. The backside of that handout specifically talks about babies who were exposed to opiates before birth. And this does walk through both, whether it be a pharmacotherapy, methadone or buprenorphine, or an illicit opiate. Talks about neonatal abstinence syndrome, talks a little bit about what they should know and things that they could expect. The backside of that handout as well. This is the final handout they have, which is good care for you and your baby while receiving opioid use disorder treatment. So the thing I love about this handout is there is life after pregnancy. In the world, when we are in the obstetric world, a lot of us like package that into this 9-month package plus 6 weeks postpartum, and then we send you off into the wilderhood. This reminds women that there is a whole next stage to your life, which is the same with recovery. There's a whole next step to your recovery. The backside of that handout. So your resources, in summary, are primarily if you are specifically dealing with a woman who has substance use disorder, if that's opioid use disorder or other, and you are feeling that you are out of your league, you can always call. If you have a local addiction team, you can always call Dr. Smid and I with the Super Rad team. We can help you navigate where to go. You can go directly to that website for the within the Utah Department of Health, and it will help you know what might be in your area or your neighborhood. And then Ultimately as well, if you feel comfortable and it's something that you've dabbled in or practiced regularly, to go ahead and keep taking care of your patients, even if it's that you need to call for just a little phone a friend help. Our last topic of the morning is just a really brief look at child welfare and to report or not report. We are looking specifically at making reports to Child Protective Services. Now, this is a really difficult thing to navigate because every state has their own law, which then is also handled a little bit differently within every county. So my first take-home message is to make a friend within your local jurisdiction so that you have someone to answer your questions. We have a very good close friend and contact here in the Salt Lake Valley who helps us, and it is probably at least monthly, but likely every other week that I'm calling to say, can you help me answer this one? I've got a patient asking a question. I'm not sure what the answer is. The other thing is, as an obstetrician in the state of Utah, if you do not care for children, so if you're a family practitioner and you're going to care for this whole family, you're going to care for the neonate, you're going to care for the neonate as it becomes a child, then it's a little bit different. But if you are an obstetrician and you care for moms, pregnant moms, and women, it is not your responsibility to report, because in the state of Utah, when that child is in utero, it is not a child and not reportable. It is once the child is born that we have to differentiate to report or not report. Big thing whenever you're talking to patients about Child Protective Services is to help frame that it is not a punishment. The goal of Child Protective Services all across the country is to help families be families, children be safe, and there be a safe way to navigate life. It's a scary thing. People feel very attacked. People feel like their character's being attacked. And to help mamas understand that if they can work with Child Protective Services, if that's what has to happen, then ultimately they can receive some really good outcomes. I have a handful of women who have either asked to open their own case or asked for their case to remain open because the services they had received and the support they were receiving was helping them better their parenting so much that they were not ready to walk away from Child Protective Services when the judge put down the gavel and said their case could be closed. We have a bill here, Bill 244, which actually largely changed how the law works, and we're going to go into that just for like 30 seconds so that you know and have a general understanding of when we do report and when we don't. And what that all stems to is this form that's called a Plan of Safe Care, and we're going to look at that together. Number one thing I can tell you about child welfare and about your patients is if you just put it out on the table and have a conversation, you have let one of those elephants out of the closet. Because every mama coming through your door is afraid that their baby's going to be taken away from them, which is a really nerve-wracking thing. So a couple ethical questions at hand. I'd like you to think these through. If you're sitting with a group of people, you might want to take a break and have a conversation about them. But should we punish women who cause their babies harm by using drugs? The follow-up question there would be, should we punish women who do not have controlled blood sugars or who don't take their hypertensive medications? And the second question would be, should we routinely take away babies of mothers who test positive for illicit substances? Which would lead us to think about, should we be routinely taking babies away from mothers who smoke or who might have addiction to cell phones? I just want you to think through it. It's an ethical situation that most of us don't have control over, but it also is something that sits really heavy for a lot of us and is a lot of implicit bias in a lot of us. I want you to remember that you became a healthcare provider to care for everyone, and that ultimately you are not the one who makes the decision, but you've got to sit within the thought process of Child Protective Services. And that may be that you feel like some days there are children who maybe you feel like shouldn't be in a home and are, or the opposite. Maybe you feel like there are children who should have been in a home and they are not. There is not a whole lot of control, in fact, no control you have over that. But just think through the questions because you will be faced with them, whether that be by a patient, a family member, or a community member who realizes what you do for a living. This provides you the link to House Bill 244, and what it actually provides you to are the entire bill and then the amendments that were made in 2020. The bill was passed in 2019. Previously, any woman who admitted to illicit substance use or who was known to have illicit substance use at any point in time in their pregnancy, so even one time, was a mandatory report at the time of delivery. So that's a woman who doesn't even know she's pregnant, who smokes marijuana at what would be the equivalent of 4 weeks of gestation, who finds out she's pregnant at 6 weeks of gestation, who completely cuts off all marijuana, would still technically, in the previous law, require a mandatory report. Now, when House Bill 244 passed, what it did was it went ahead and looked specifically at the chronic illness of substance use disorder, and it said just because you have a substance use disorder, that does not mean you're not a good parent. So it is no longer a mandatory report as soon as you know that a woman has the chronic illness of substance use disorder. That's where it gets tricky, because it is looking at the whole picture now. So if there are other factors that make it seem like it is an unsafe home for a child, or the individual is unsafe to parent the child, that is when the report gets made. Now, to design that, specifically, when you as a provider find that an individual has a substance use disorder, you are supposed to put into play what we call the plan of safe care. It is a two-sided document, which is available on one of your handouts, but also accessible online, of which lists this woman's support systems, medications, and her plan for managing her chronic illness. Here within the Super Rad and University of Utah team, the first time we meet a woman, she starts on the journey of filling out this document. It sometimes takes us 1 visit. It sometimes takes us 4 visits. Sometimes we are adjusting it every 3 or 4 visits. But in the end, when a baby is born, if we have other unsafe factors or other concerns, of which results in a Child Protective Services report made by our social work team or our pediatric team, this mom has this plan of safe care in her documents and in her chart to be able to say, this was her plan, this is where we were headed, this is what was going on. It is a privacy HIPAA document, and part of the document is that the patient signs it to say it is okay for you to talk to the rest of my care team. So if they're participating in a methadone clinic or if they're in a treatment program, that you could talk to all the entities involved. Part of that also is if a case has to be opened, the document can help to navigate who are the players to talk to figure out what is really going on and how can we help support this woman in being a parent and navigating her chronic illness. In wrapping up, I always like to do a few thank yous. To be honest, my biggest thank you are to the patients that I care for. I've been in practice for 9 years. I started as a family practitioner and mostly took care of pregnant mamas and their children, which was a really beautiful gift because you get to see a whole family and you get to see them grow and progress. But 5 years ago, I joined the team at the University of Utah and care for pregnant mamas now. And lucky for me, many of my mamas stay with me long term because although we are a pregnancy clinic, a high-risk pregnancy clinic, we do keep our mamas for a year postpartum or more. So I do get to see their kiddos grow. And my patients teach me more than I learned in school and then I learned in reading articles and attending talks like these. I navigate most of the world that I navigate of substance use disorder through individuals who talk to me about life experiences and what's going on out there in the trenches. I always like to thank Dr. Marcella Smid. Like I said, I am a PA by trade, and Dr. Smid has been kind and wonderful and a really good friend and helps to navigate the world of living this life and doing this together. She also makes a bunch of your slides, and so I thank her for that. My Super Rad team, like I said, we are a team of 25 plus or minus. Every one of them gives every piece of their heart and soul to care for women with substance use disorders in pregnancy. I have a wonderful family who allows me to come to work and work more than the average individual and still welcomes me home with open arms. And then my team at PARCA, who is our research division team, who affords the opportunity for patients who participate in research studies to feel like they have a meaning in the world because they know they're making a difference for other people. I'm always available for questions. You have my contact information. Super Rad's contact information is in your handouts. Please feel free to reach out. Again, thank you very much. And if you take home anything, just remember that people die from their substance use disorders and that it is their individual journey. So when you're screening, work with them and for them and on behalf of them. Don't do it for them. Because as a healthcare provider, we are privileged and blessed enough to be welcomed into the uncomfortable and comfortable worlds of individuals. And every one of them is an individual, and they're going to figure out what's best for them to navigate the world. Thank you.